Hi, my name is Megan Landry,
I'm Johnny Hutchinson.
and we are group three, and our condition is Guillain Barre Syndrome. And our group consists of Adrian, Josh, Carson, Taylor, Lauren, and Nia.
Okay, so first, let's talk about what is Guillain-Barré syndrome. Guillain-Barré is a rare neurological disorder where the body's own immune system attacks the peripheral nervous system. This can lead to muscle weakness. This can lead to numbness. This can lead to paralysis. Typically those symptoms start in the legs and then work upwards to the upper extremities. Um, Guillain-Barré typically presents after an infection. Could be a respiratory infection, could be a gastrointestinal infection. Those are the most common. And the exact cause of Guillain-Barré syndrome is unknown. The treatments can vary, but typically the prognosis is good for patients. But that can vary as well, and we'll get into those details coming up.
Okay, so we're moving on to the incidence and the risk factors. So Johnny just kind of said that this condition is rare. So even though that it is rare, it's something that we need to be aware of in our clinical practice. And it is more common in adults than children. If somebody's above the age of 50, they're at a greater risk for developing Guillain-Barré syndrome. And you typically see it more in the male population than the female population. And with race and ethnicity, it doesn't matter who you are, that you are still at risk for developing this syndrome.
All right, let's talk about the etiology of Guillain-Barré. As I mentioned in the intro, typically we see this after a respiratory or gastrointestinal infection. The most frequent infection associated with Guillain-Barré is Campylobacter jejuni, um, but it's also been seen in a number of other viruses, such as CMV, the Zika virus, herpes, Epstein-Barr virus, COVID-19 virus, and we're going to talk about why those viruses can lead to Guillain-Barré syndrome.
Okay, so going into the pathophysiology of EBS, we'll start off with molecular mimicry. And this is one of the key mechanisms behind GBS. So, this is where the proteins on the surface of a pathogen resemble the proteins found on the peripheral myelin nerve or the peripheral nerve myelin. The immune system is trying to fight off the infection, but it kind of gets confused and it results in attacking the actual myelin sheath around the nerve. Um, as a consequence of this, you end up having demyelination. So we're moving into the next part. And the immune system actually attacks the myelin sheath and it ends up disrupting the electrical signals going to the muscles. And so that's why you'll see a lot of patients that have GBS, they'll have a lot of muscle weakness and paralysis because the nerves can't effectively communicate with the muscles. In addition, we go into inflammation. So, where there's damage in the myelin, there's also going to be inflammation in those areas. And the cells from the immune system, like the lymphocytes and the macrophages, they'll infiltrate the nerves and continue to damage it further. And then moving into the axonal damage. So, in some cases, like acute motor axonal neuropathy, which this is a subtype of GBS, the immune system response doesn't just stop at the myelin, like it'll just keep on going. And so it ends up damaging the nerve axons itself. And this can result in more severe and prolonged weakness because the axonal damage takes much longer to recover compared to the demyelination. And then lastly, the syndrome doesn't just affect the muscles, it can affect the autonomic nervous system, which controls our things like blood pressure, heart rate, and digestion. And so you'll see fluctuations in all of these, and these symptoms can be very dangerous. So it's just important that we are able to monitor those symptoms.
And as Megan mentioned before, there are different subtypes. So Guillain-Barré generally presents in a very similar way, but different things can be affected in those different subtypes. So on the right in box C, you see a normal motor nerve. You see the axon, you see the myelin sheath. you see spinal cord, and you see kind of the peripheral nervous system innervating a muscle. And we look at box A on the left. This is an example of acute inflammatory demyelinating polyneuropathy. So this is where those proteins from the infection resemble the proteins on the surface of the myelin sheath, and the immune system goes to get rid of those, tries to help with the infection from the illness, and it accidentally gets some of the proteins that are associated with the myelin sheath, thus damaging the myelin sheath. And we see the demyelination, and we see the ability or the lack of ability to properly conduct that nervous uh, signal to the muscles. And if we look at B, the acute motor axonal neuropathy, that's where we see actual damage to the axon itself. Um, and this can cause to complete paralysis. You see that picture at the bottom, it's not able to send a signal at all. Source A, we had a slower conduction, and B, we have no conduction at all, so no ability to contract the muscle. And that is when the axon is damaged. So if we go to the next slide, we're going to continue talking about some of these subtypes. Um, we talked about the acute inflammatory demyelinating Guillain-Barré subtype, but this is polyradical neuropathy. It's a multifocal peripheral demyelination. It's slow. It, it, it presents with slow remyelination. So remember, we talked about the demyelination, the effects. We were still able to get that signal to the muscle, but we saw it just not able to do it as quickly. So we're going to see maybe some symptoms like muscle weakness and absence of reflexes. Can often be associated with sensory symptoms as well. We move on to the acute motor axonal neuropathy. As mentioned before, this is where we attack the axon itself. There are specific antibodies that are associated with the pathological effect. But in the clinic, it sort of looks like no movement whatsoever, no contractility of the muscle whatsoever. This is most associated with Campylobacter jejuni infection. So if we think about a GI infection, we think about maybe some spoiled food or some food poisoning. So that's why we might see it in the summer months of Eastern Asian countries. There are also other not as common subtypes: acute motor and sensory axonal neuropathy, Miller-Fisher syndrome, pharyngocervical variant, where we see those symptoms, the muscle weakness, the paresthesia, more associated with the cervical spine and the pharynx. Diagnosis of Guillain-Barré syndrome. We talked about this already a little bit, but there's autonomic involvement, cranial nerve involvement, um, sensory involvement, and a couple other things that we can look at to make sure that it is Guillain-Barré syndrome. So autonomic involvement, we're thinking about blood pressure, we're thinking about respiratory rate, cardiac arrhythmias, cranial nerve involvement. This can occur in 30 to 50% of cases and affect the face, the muscles of the face. So cranial nerve 7. For the most part, it's relatively symmetrical, the presentation of it. So it can affect the lower and upper extremities symmetrically. Sensory involvement we mentioned before, but then a couple other key factors, the cerebral fluid findings, we're going to see elevated protein levels as well as elevated white blood cells. So that immune response again. Slowing or blockage of the nerve conduction leads to that slow muscle contractility or no muscle contractility at all. And this can occur in 80% of cases.
Okay, so we're continuing the diagnosis. So a lot of times you're going to see that progressive weakness of more than one limb. And kind of in the slide before, we talked about where these symptoms will usually peak. So kind of going in more depth about that. Um, 50% of patients you will see peak within 4 weeks. And then oh, sorry, 2 weeks. And then by 3 weeks, 80% of cases, they'll see their peaks then. Also, you'll see absent or decreased tendon reflexes in the affected limbs. If the tendon reflexes aren't going to always be absent, they'll just be a little bit diminished. So if this happens at any point during the clinical course, it helps us to support the GBS diagnosis.
Prognosis, as I mentioned in the beginning, is usually pretty good. So complete recovery in about 70 to 80% of patients within the first 6 to 12 months regain total function or near normal function. There are cases where residual symptoms occur. So 20-30% of patients with GBS see residual symptoms. And those are the same symptoms we talked about earlier: muscle weakness, fatigue, sensory issues, and even the autonomic dysfunctions. Uh, so functional limitations, these muscle weakness, fatigue, sensory things can impact the activities of daily living and keep patients from returning to full function. But for the most part, it's pretty good. And prognosis is directly correlated with age. So the older you are diagnosed with Guillain-Barre syndrome, the less good your prognosis is going to be.
So we have some assessment and outcome measures that we can use for this condition. So some specific measures, we can use the overall disability sum scores, GBS disability scale, modified Rankin scale. Some impairment level assessments are sensation, passive and active range of motion, manual muscle testing, deep tendon reflexes, cranial nerve exam, respiratory function, and the pain scale. Some activity level assessments. We can use the FIM, Barthel Index, 10-meter walk test, the Berg, 6-minute walk test, tug, 5 times sit to stand, and some participation level assessments is the SF-36 and sickness impact profile.
All right, so interventions, what do we want to do with these patients during the acute stage? We want to make sure that their respiratory function is going well, so we can work with a respiratory therapist. Um, we can sit them up in bed so that they're able to breathe a little bit better. Functional activities, we want to make sure that those ADLs aren't forgotten about, and we can work on things like feeding and grooming and bathing with the patients. We can work on range of motion exercises so that they can maintain their prior range of motion after the diagnosis. And like I said, we can work with respiratory therapists, we can work with occupational therapists. We can just work collaboratively with the rehabilitation team. We want to manage their pain. And since some patients are unable to move at all, we want to make sure that they're not developing pressure ulcers or pressure sores. So we want to manage that. And then the last thing, without that contractility of the muscle, there's not as much venous return, and we might see some swelling. So we want to make sure we're managing that with some sort of wrap or some pump on the legs to keep that blood flowing.
And so interventions for the chronic stage, the therapist will gradually introduce some active exercises, and it's important to monitor the patient's fatigue because if they are fatigued or, you know, overexerting themselves, it can exacerbate their symptoms. So we just want to be mindful of that. And anti-gravity strain should be avoided unless they can do a manual muscle test, grade 3 out of 5, which is where they can do that full range of motion against gravity. The initial treatment should be low reps, high frequency over short sessions. Some multi-joint movements like PNF patterns can be really useful. And we want to work on some gait and progressively get their gait efficient. Also, we should include some aerobic exercises, strengthening activities, and functional training, obviously with the modifications, because again, they have some respiratory dysfunction, so we want to make sure that we're monitoring their symptoms.
All right, and here's some facts from the research. We mentioned a few of these before, but this is just some things to keep in mind as you're creating your plan of care. This has been shown to work best for patients diagnosed with GBS. So just take a look at these and make sure that you're incorporating something like this in your plan of care for patients with GBS.
Any questions?
Thanks for watching the video. We've included some NPTE questions at the end of this PowerPoint so you can test your knowledge on Guillain-Barre syndrome. So go ahead and take a look at that, check those out, and test your knowledge. Thanks for watching.
Thanks, guys.